Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. We have the honor of having Ibe Cherian, a well-known educator from in neurosurgery. We've been doing these webcasts for a long time, and I'll let Juha do the proper neurosurgery introduction. Welcome, Juha.
Thank you. Hello, everybody. Welcome, Ibe. So, I give a short introduction on Professor Ibe Cherian, who is now at the moment he's Director of Neurosciences, Krishna Institute of Medical Sciences, Karat, Maharashtra, India. Professor Ibe Cherian made his medical training in Kerala, became medical doctor there, and after that made his neurosurgical training in a famous institute of Vellore, India. After, as a specialist, he moved to Nepal, northern part, north of India, and has been 14 years working there and building up 3 neurosurgical centers south of the main capital, Kathmandu. So how to become a good neurosurgeon? I never saw anyone who wanted to be a bad neurosurgeon. These are the old rules: train hard and learn anatomy. And this is what Professor Ibe Cherian has certainly done. There are different levels of manual skills. It depends on number of repetitions and length of career. The general old rule is that with 10,000 hours of training, you are at the world top. And my own rule that with 10,000 days in operation room, you are at the best. These days are still ahead by the Professor Ibe Cherian, very young at age now. So neurosurgery has 3 parts: operative skills, research, clinical and basic. Most important publications of Professor Ibe Cherian are on cisternostomy and brain injuries. He will speak about that in the following lecture. And then this teaching is one of the 3 important parts of neurosurgery. Ibe Cherian is well known for his teaching, has made and giving all the time many dissection courses. He has many fellows around the world, and he's very active in webinars and also involved in World Federation of Neurosurgery. I had the pleasure to join Professor Ibe Cherian in Biratnagar Nobel Institute for 1 year before coming to China, and he had a wonderful institute, and with his active surgery skills, he could do many very difficult cases and treat the Nepalese people. Since more than 1 year, he moved back home to India, to the institute, Krishna Institute, I mentioned in the beginning. Train your best young people. They should become better than you. This is a very good sentence, and Professor Ibe Cherian, like I told, is a very good educator for young neurosurgeons, very active in that respect. So, without more words, I give the words to Professor Ibe Cherian. I thank you very much. Seisheni.
Thank you, Juha. We definitely miss the time that you were with us in Biratnagar. Definitely miss the guiding light. I mean, whenever we were doing very difficult cases, it was always great to have you in the background and also learn a lot from you, seeing how clean and more than everything, I was so impressed and I learned from the kind of courage and the confidence that you have. Of course, it comes from years of experience, but that was something, you know, that marks you out, separate from others. So my dear friend, I'm honored to be talking in your meeting. And today I thought I'll do something different. There are so many lectures. I mean, about a month back, I just gave an ACNS lecture for cisternostomy with it was hosted from Malaysia, and everything, all the cases, everything was shown there. And today I thought I would tell everybody as to what is the philosophy. Why would anybody do cisternostomy? Why would anybody want to change? We've been doing something for 100 years, and why would you want to change at all? And why would you want to do a more difficult surgery than DC with more infrastructure, more learning curve, and more difficulties for the young neurosurgeons? Why would you want to do it? This is what I want to discuss. So I have with me a few young neurosurgeons who are already doing cisternostomies. And in the audience, I'm sure I would have to have a lot of doubts. And if they ask me these doubts, we are going to discuss, and maybe Yuha can also help in telling them how to open cisterns, because he's one of the most talented microneurosurgeons that I've seen. I mean, who've opened cisterns in less than 2 minutes up to the basilar. So I've seen that happen. So, and even in tight brains, like multiple bleeds, he can also manage to do that. And he does that with the LSO incision. So if we do a little bit more skull base, I'm sure everybody, I mean, you don't have the kind of experience that Yuha has, but even then, if you can do a little bit of skull base and drill the sphenoid ridge off, you can get into the cistern. It's not a big problem. So this is what I'm going to talk to you about. And since I know Bin and Takashi are translating, I will try to be as slow as possible. I will like to start from how we figured out what is cisternostomy. So back in 2007, that was almost 14 years back, I had some training in microvascular surgery. My training was with Professor Sano, and I was trying to, there were two cases on one day. The first case was an aneurysm. I mean, there were two cases. One was an aneurysm and one was a severe head injury. Now, what happened is that it was a weekend, and I asked my junior consultant that you post the aneurysm first, and then I'll go take the trauma later. I mean, he can do the trauma later. As every junior consultant who's had some interest in microvascular surgery, I was not really interested into trauma. I had done enough trauma in my residency in Vellore, where we had one of the largest trauma lots probably in the world. I mean, we are not talking about China, but otherwise we had a lot of trauma load, and I was done doing trauma. So I said, get the aneurysm in first. And then after that, we'll go do you can go do the trauma. Now, what happened is we didn't have these smart cell phones at that time. We had only that small cell phone. So I called the OT, and they told me the case is started. So I waited for the craniotomy to be done, and then I went in. And when I went in, I saw that it was a really angry brain. And he was opening the dura, and I could see that it was a very angry brain. And I thought, it's just as usual. It's a ruptured aneurysm. So I went in, retracted the base, the frontal base, got into the optic nerve, opened the opticocarotid cistern, let out some CSF, brain started becoming lax, and I started opening the lateral optic. At that time, I was not skilled enough to open the membrane of Lilliquest. I had to go later to Japan to learn how to do that. A lot of people ask me that question, that they don't open the membrane of Lilliquest. I tell them it was the same way I started. So I did not open the membrane. I opened the anterior cisterns and I started tracing the A1 from the IC bifurcation. I opened the proximal sylvian. I started tracing the A1 back to the aneurysm. As in my mind, I know that this is a superiorly pointing or a laterally pointing aneurysm, or I was looking at the A1 ACOM junction and I couldn't find any bleed there. I couldn't find any aneurysm there. And this was I had a very few aneurysm experience in 2007. And I started getting a little bit nervous because when you don't find an aneurysm, this is a strange feeling that, you have these butterflies in your stomach. It's okay. If the aneurysm is found, then half your heart becomes, it becomes okay, but don't find an aneurysm, this is crazy. So I started looking for the aneurysm. I thought it's probably a posteriorly pointing one. So I tried to open the arachnoid more and more in the hemispheric, took out some gyrus rectus, looking for the aneurysm everywhere. I couldn't find it. So after 1 hour, I started sweating. And I told my assistant, I cannot find the aneurysm. It's really difficult. So this guy, he's telling me at that time, can you imagine? He's telling me, this is not the aneurysm, this is the trauma. So for a moment, I wanted to hit him, and I said something to him, which I don't want to translate right now, but I said something to him in Malayalam. And I told him that I put the microscope on and I was searching for the aneurysm for 1 hour. Why on earth did you not tell me that it is not the aneurysm? So he told me, you didn't ask. And he said, I was equally puzzled that you put on the trauma, you put a microscope and then you started you started opening cisterns and you started doing all these strange and crazy things. So I understood it was my mistake. And I asked him, why? Why did you post the trauma first? He said the trauma dilated one pupil. So he was correct in every way, and I could not say anything to him. And I was crestfallen because I had to come later in the night for the aneurysm and then do it and then go back very late in the night to my home on a weekend. But I did it. I didn't say anything. And the next day morning when I came, it was stunning to see that the trauma scan was pretty bad, but this guy was literally tugging at his tube. So at that point, I thought maybe the brain was lax. And although we didn't put the bone back because our teaching was that we should never put the bone back. So, he had done a large craniotomy and I did not put the bone back. And the brain was not at all, it was not like the usual decompressives, it was lax. The brain was lax. So you could feel the pulsations very well, and the patient was literally tugging at his tube. So this thought crossed my mind. I thought, okay, maybe if you open the cisterns for this trauma, the brain may not be so tight after all. So we started opening the cisterns. And this is how the surgery started. So the best way to start a cisternostomy is to mistake the trauma for an aneurysm. That's lesson number one. You don't think that you are doing a trauma. Think that you are doing a ruptured aneurysm. Go to the base, open the cisterns, start opening all the cisterns and one by one. And then after that, you put a drain and come out. Your bonus is that you don't have an aneurysm to click. So you don't have to worry about an aneurysm rupturing on you. So this is lesson number one for every young neurosurgeon who's hearing me. Lesson number one is confuse. How I started, confuse or think that it is an aneurysm. So how are you going to deal with an aneurysm? In a ruptured aneurysm, you cannot go. Obviously, if it's a ruptured aneurysm and the brain is tense, you cannot go and start opening the sylvian. It's difficult. Okay, you have to go subfront. You have to let out CSF from the opticocarotid system. Will tell you. I would ask him. Maybe I can ask him now. If the brain is really swollen, what is your strategy? You are muted, Juha.
Under the microscope, I go subfrontally through a very narrow space and go to the cisterns you mentioned and open also lamina terminalis. And this is the way to have a slack brain. And then many times I open also Liljequist membrane with first the anterior cisterns and lamina terminalis. This is the way I do. And you can do under microscope, you can go through extremely small cap, narrow cap. So it is only a few millimeters you need. And then you get space. You have to be patient, but you can do it also rather fast if you know the tricks. Okay, go ahead.
You must have seen some really tight brains. And even if in tight brains, if you open these cisterns, have you seen these brains getting really lax?
Yeah, of course. This is the way. You cannot, in that kind of red, angry, swollen brain with ruptured aneurysms, you cannot begin with the dissecting for the aneurysm. You have to get the slack brain. After that, everything is like regular neurosurgery. The first thing is to get the slack brain. And one of the important things here is the good anesthesia. So this is what we had in Helsinki, extremely good anesthesia. This is a big difference in many places I have seen around the world. So good anesthesia helps a lot in this undertaking.
Yeah, thank you. So who better than Juha can tell you if there is a tight brain, the first thing that you need to do is to open the cisterns. Go subfrontal, go to the optic nerve, retract the brain. The moment you retract the brain, you are going to get the arachnoid between the optic nerve and the frontal lobe breaks, and immediately you'll have a gush of CSF. And if it's a tight brain. And after that, you can use a scissor or you can use a dissector to open the arachnoid, extend that arachnoid opening over to the carotid. And then you can use the scissor in the lateral carotid segment and in the opticocarotid segment, and use a suction and a scissor, and you can easily open the membrane of Liljequist as well. And this is going to get your brain very lax. Okay. Now, so this is how we started. That is lesson number 1. So opening cisternostomy is a surgery that is a starting point for every aneurysm surgery with a tight brain. It's not a separate entity. It is not something that I started on my own, or it is not something that is completely new and sprung out of the earth. No, it's not. It is a prelude. It's a prelude to every aneurysm surgery with a tight brain. This is what every aneurysm surgeon does. So you don't have to ask me the technique for cisternostomy. How do you do it? What are the things that you must, of course, take the sphenoid ridge. You must try to get into the cistern. There are some basic things. And every neurosurgeon in the world who does vascular surgery, who does ruptured aneurysms, they are familiar with. And on the other hand, if you can do cisternostomy properly, then you can get into the cisterns and deal with aneurysms. Not if you do decompressive. If you're doing decompressive, it is a 100-year-old surgery, and it does not prepare you for anything except to panic and throw out the bone and have the brain to herniate into that defect, create unethical type of damage to the patient, and then come out. This is what you do with a 100-year-old surgery. But cisternostomy, no special technique. What every vascular surgeon, experienced vascular surgeon would do in the face of a swollen brain. So lesson number 1, that's over. Now 2, we need to figure out how the traumatic subarachnoid hemorrhage and aneurysmal subarachnoid hemorrhage is similar and different. Now, how is it similar? Both are subarachnoid hemorrhages. So, what happens actually? Now, it's a challenge to do this without a PowerPoint, but I'm going to ask you to use your imagination. Okay, this is something that we rarely use this time. Imagine at the base of the brain, we have 120 ml of CSF. Can everybody see that? At the base of the brain, you have 120 ml of CSF. This CSF is not just to suspend the brain. This is point number 1. Till before, everybody thought that this 120 ml of CSF is there to suspend the brain. No. What happens with this? This CSF goes through the Varsha-Robin spaces around the vessels into the whole of the brain. So this suprasellar cistern CSF, the cisternal CSF, is in complete communication with the brain parenchyma through Varsha-Robin spaces. This is lesson number 2. This is your take-home message number 2. The CSF in the cisterns, not in the ventricles. In the ventricles, they are being produced, and from the ventricle to the brain parenchyma, there's no communication. That's a production cycle, lateral ventricle, third ventricle, fourth ventricle. No communication with the brain. But the moment they come into the cisterns have all these small vessels which go into the brain, and around these small vessels we have Varsha-Robin spaces, and the CSF gets into the brain through these Varsha-Robin spaces. Okay, that is take-home message number 2. Now, imagine there is subarachnoid hemorrhage. That's the most. Yuha, I understand. I will show slides, but I was with CSF shift edema has been published. I just wanted to tell them about CSF shift edema, and after that, I'm going to take questions, and we are going to talk about how can a junior neurosurgeon do cisternostomy. I'm going to have some of my fellows also. I didn't want the PowerPoint slides today because I just wanted to take it as a class with a lot of interaction from everybody. So I was going to tell you that if you have subarachnoid hemorrhage, where does the hemorrhage happen? The hemorrhage happens in the cistern. And when you have bleeding in the cistern, the pressure in the cisterns go up, and all the CSF in the cisterns shifts into the Varsha-Robin spaces, and this phenomenon is called CSF shift edema. Imagine you take a 1.5 liter Coke bottle, try to inject 100 ml of saline into that Coke bottle. You know, the Coke bottle will explode. It's exactly what happens when traumatic subarachnoid hemorrhage happens. Traumatic subarachnoid hemorrhage happens, the cisternal pressure goes up tremendously, and the CSF in the cisterns gets pumped through the Varsha-Robin space. We already told you the Varsha-Robin spaces are communicating with the brain. So the CSF goes into the Varsha-Robin spaces, and 1500 ml of brain into that. The Varsha-Robin spaces are part of it, like canals into the brain. They go into it, and the brain the intraparenchymal pressure becomes, it just shoots up. That is why if you make a small opening on the surface, the brain will just pour out. People call it brain fungus and so many other things. If you open a decompressive hemicraniectomy in this picture, you are going to have a 12 into 13 centimeter defect, and the brain comes out by about average 1 to 2 centimeter out, herniates out. And you think the ICP is okay. ICP gets better. It is just the amount of CSF that went in. That's the volume of brain that comes out, herniates out. It's strange. And when that herniates out, that hemisphere of the brain is gone because the brain is put under tremendous stretch, axonal stretch, damage. And 6 months later, when this patient comes back to you, that brain shrinks to 30% of its volume. You can see that. I mean, there'll be nothing left. And you put the bone back and you take a scan, you will understand that the brain is shrunk to almost 30% of its volume. You're lucky if it does. This is what happens in decompressive. What's happening in cisternostomy? You're just reversing what has happened. The cisternal pressure was high, so you open the cisterns and drain out the blood. The cisternal pressure becomes lower, and the CSF from the brain comes back into the cisterns, reverses the CSF shift edema. This is exactly what we want. It's physiological. And this is what we want. Instead of putting the brain through such stretch. So this is the philosophy of cisternostomy. I told you how we started cisternostomy, and this is the philosophy behind cisternostomy. And now I'm going to show you videos. I'm going to share my screen. I'm going to show you some cisternostomy videos. Okay. Okay, I'm sharing my screen. Can you see my screen?
Not yet. It's not sharing yet.
Okay.
Yeah.
No, it's 1 second. Let me try. Cisternostomy. Okay, it's just not sharing. Okay, I'm going to show you the tech. 1 second. John, okay, I'm sharing now.
Yeah, Dr. Nilesh has put on a link of you doing, I think, in a video. Do you see the link in the panel that Dr. Patel has posted?
I mean,
that may be a video. I don't know. Is that a video, Nilesh? Perhaps not. Just hang in there. I put it back. I think it may have fallen off. It'll be a second. Just be patient. Oh, it too. Oh. Okay, there we go. Using your smartphone
Yes.
as a backup. Oh, we fell off. Be patient, everybody. Sometimes tech does not cooperate. He's coming back in. Nilesh, are you there? I don't know. Okay, just wait. Well, I'm still waiting. Oh. I don't know what happened.
Where is Jaip now?
He hasn't come back in yet.
Is there connecting? Yeah.
Okay. And Dr. Van Cole, who's also there, hasn't come back in either. I wonder if they had an internet problem in their hospital because they're both
Sabine
not.
is in operation room, I think.
Oh, okay.
But the Liao is.
Can you hear me? Can you hear me?
Yeah.
Yes.
Yes.
Okay, I'm gonna share the screen right now. We had a problem with the net there. So yes, I'm sharing. So to see, I hope you can see the. Okay.
Yeah. Yes, we can see it.
Right. So we're going to show you countless. I mean, I can show you some cisternostomy videos, Right. We'll be talking about.
Recording in progress.
Right. So that is the usual positioning. That is the usual positioning, large flap. And then once you're done with that, you have your frontal lobe, temporal lobe, and you completely drill this flat. And this is something that you do for getting into the base easily. So for the junior neurosurgeons, if you're doing it, you have to take as much as sphenoid bone as possible. And that's what you need to do. Okay. And this is the anatomy. Once you do that, this is the anatomy. So that's your optic nerve, your frontal lobe is retracted, your optic nerve, your carotid, and this is your window for cisternostomy. This is the same for every vascular surgery. This is nothing different. And the arachnoid that you find in this opticocarotid window, multi-layered arachnoid that you find in the opticocarotid window and lateral carotid window is nothing but the membrane of Lilliquist. So if you know where your PCOM and the anterior choroidals go, you can open this arachnoid here and you can see the basilar. This is nothing big. You do that. That was exactly what Juha was telling. He'll open the interoptic, opticocarotid. Sometimes he said he'll open the lamina terminalis as well. And interoptic, opticocarotid, lateral carotid. The arachnoid here needs to be opened and the membrane of Lilliquist can be opened through the opticocarotid window, and lo and behold, cisternostomy is done. That is all. Nothing big, nothing complicated. Okay. So a cisternostomy video from many, many years before. That's your optic nerve. That's your other optic nerve. The subdural has been evacuated. And that's not the actual speed. That's the membrane of Lilliquist. So what you see is the perforated membrane of Lilliquist. That's the other contralateral optic nerve, ipsilateral optic nerve. And that's a carotid, that's a bifurcation. Once you open this cistern, the brain is much, much laxer. And then you go ahead and open the membrane of Lilliquist. This video is from 9 years back. And then once you open that, you see this. That's a basilar, superior cerebellar, P1 and P1, and that will be the third nerve, lateral to the carotid. That's what you will see. I'll show you now. So optic nerve, carotid, basilar, superior cerebellar, and P1. That's a basilar. So after the cisternostomy is over, this is what you see. Again, sometimes you need to do an axial unlocking, but let's not really talk about that because that makes. Earlier, I used to talk about this and people used to get completely confused. All the young neurosurgeons used to get completely confused and, you know, most of them wouldn't do it. So that is not the whole purpose. So see, again, I am going to leave the part where we started doing cisternostomy through a supraorbital window. Don't do it. Okay? Don't do it because at the end of the day, if you are comfortable taking out just a burst lobe and a little bit of subdural through the suprabrow window, but if not, use a standard big flap for cisternostomy. These were times when we started making things more and more fancy, but no. Again, this is a posterior clinoidectomy that we use. Now we use it only for basilar aneurysms, proximal control. We don't use, earlier we were using, when we had a huge PCP like this and we could not open into the posterior cisterns, we were using PCP drilling. These days it's not required. As experience comes, These maneuvers are not required. Okay. So again, this is, although I'm showing you this, there is no requirement for this. Okay. So at the end of the day, what is a cisternostomy? The cisternostomy is nothing but something that you do in the beginning of every aneurysm surgery, opening cisterns. Everybody, every neurosurgeon in the world does that. No difference. There's nobody. There's no specific technique for cisternostomy. Okay, I'm going to search for a few more. There's this Dr. Parthiban who's doing cisternostomy. So for example, Parthiban's technique. So he's another surgeon doing cisternostomy. So let me show you. It's the same thing. Under the microscope, not under the loop. Okay. So he's going below the frontal lobe. That is the optic nerve there. So he's opening the arachnoid there. You're going to see the optic nerve and the carotid, opticocarotid arachnoid there. That's a frontal lobe which is really tense to start with. But once you open the arachnoid, you will see the optic nerve there. Keep on washing. Keep on washing. A tight brain makes maneuvering very difficult, but you can already see the optic nerve there very beautifully. And you keep on opening the cisterns and letting out the blood from the cisterns and keep on extending this arachnoid dissection. So you can see the optic nerve there very clearly. It's going in from a subfrontal perspective. Parthiban just published his experience in Neurology India. So, well, we have the Swiss group now from Roy Thomas Daniel and his group. Now we have a group from Brazil, Aline and Dr. Jesus, their experience, huge experience. It's on the cover of the Brazilian Neurosurgical Journal. We have Samer and group from Iraq. We have Parthiban from India, many more from India. We have Wang from China. Well, we have Shiraz University, Iran, and so many more who is doing in different ways. So we can see he is slowly going on and opening the cisterns very patiently. This is not like decompressive hemicranectomy. It's not an open and shut surgery. It's not like decompressive hemicranectomy, which is easy. This has learning curve. This is difficult. This needs the microscope, and this needs somebody who's senior to assist and guide in the beginning. Today, somebody who's doing decompressive. Tomorrow, if you ask me, okay, can I do a decompressive? Can I do a cisternostomy? It's not possible. But it is a procedure which is done by every single vascular surgeon in the world. And I think we have a lot of them. Okay. So nothing big, nothing new. See the brain now completely lax. Okay. You see how much injured this brain is. See the traumatic subarachnoid hemorrhage. Okay. And do you want to keep the bone away from this brain? No way. Don't even think about it. Okay. You don't need to. All right. You can easily put the bone flap back. And if you see, there are many more videos, our videos, Wang's videos, and there are many more teaching sessions on cisternostomy. So today I wanted to, with Yuha, I wanted to tell you guys that cisternostomy is not a new or an isolated, specialized technique. It's something that every vascular surgeon does it in a tight brain. It works for trauma. Take it from me. It works for trauma. There is no doubt. I know there are non-believers, and unfortunately, when something has been done for 100 years in a particular way, to change it, it takes at least 10 years. Well, I've taken 14 years and things are changing, but it's not easy to change mindsets of people. So I would like to ask the young neurosurgeons and maybe my team, my consultants, we have here Dr. Nilesh, Dr. Nikunj, and Dr. Nargiza, who has seen all the cisternostomies and they are doing cisternostomies by themselves. And so I would ask their opinions also. Please don't think that I'm influencing them. Maybe if you want me to, I can even go out of the room. But what I want is I want you to ask all the participants. I want you to ask questions. I want you to criticize. If you think it will not work, tell me it will not work, and I'll tell you why it will work. We will have not a fighting argument, but I will tell you why decompressive will not work, why decompressive is an old procedure, and why decompressive is actually unethical. It's not the best treatment. We have to give the best treatment available for. Do you do decompressives for aneurysms anymore? Do you do decompressives for tumors anymore? This used to be done at one time, but not anymore. Once microsurgery came in, once Professor Yasagil, Professor Yuha, Professor other people started doing things, then these things became just history. Dr. Goyal is here, and Professor Goyal will tell you maybe his views on decompression of the inframen magnum and on. Decompression is not a good thing. Okay, you need to be physiological. It's wrong. Decompression is wrong. Now, if you ask me whether I would want to tell you decompressive hemicranistomy is unethical, maybe not, because it at one point of time, maybe 100 years back, decompression was standard. It must have saved quite a few lives, but we have moved on. This is the era of microneurosurgery. And young guys, no point in getting trained in a surgery which is 100 years old, which doesn't use the microscope and which needs no skill. This is not the point. So I would want each one of you to interact, talk, maybe for the next 20 minutes if we have time, talk and ask me questions. And also I would ask the juniors to take over and talk about their experience, because they have just started. They have probably done less than 10 cisternostomies, and whether they would want to do decompressive hemicranectomies anymore, I would like them to ask. Dr. Nilesh was trained with Dr. Goyal. Professor Goyal was his mentor, and he has good experience in neurosurgery. He's been one of the best centers in the world, seeing master at work. So I would want you to tell your experience.
Initially, I was trained by Professor Goyal, and the latter I joined Professor I in last 8 months. As everyone knows, Professor Goyal is dead against decompressive cisternotomy. So I have never been trained to do this Dexonian procedure. But after doing cisternostomy, we can see initially the brain will become lax after a few seconds of the opening of the cisterns, and the patient's GCS will improve drastically. And the patient's outcome is ultimately what it matters. If the patient is improving by any condition, I will always advise to do that procedure over anything, because for us, only patient's outcome doesn't matters. Anything else is just a normal procedure. So in the last 8 months, I have seen the magical results with the cisternostomy, and I will definitely recommend. And I just have shared our paper, which was published by the AIMS Rishikesh, which had shown the intracranial pressure. It actually reduces within minutes after doing the opening the cisterns, and the patient's GCS also improves in the post-operative period after the follow-up also. The patient's functional outcome is also better as compared to the decompressive craniotomy. So we are also getting the scientific evidence so as to prove, and after a few years, after a few months, there won't be any argument whether decompressive should be done or the cisternostomy should be done. We will have definitive evidence that cisternostomy is always better. My other colleague, Dr. Nikunj, will be here, and he will share his experience.
Hello, everyone. Same thing what Dr. Aipchen sir and Dr. Nilesh explained. I had the same experience that the results of cisternostomy are much. Introduce yourself. I'm Dr. Nikunj. I have done MCH neurosurgery from CMC Vellore, and I'm now 3 years post consultant following after doing my neurosurgery. So as we were discussing about the cisternostomy, the tricks, the how to do it, which has been already explained by Dr. Aip sir and Dr. Nilesh, the results, the prognosis. The only one thing that, as everybody has said, it requires a learning curve. The junior or the young neurosurgeons just require some learning curve to do cisternostomy initially. My take on that is, as a young neurosurgeons, we should always progress and should do it. We should not fear, we should not keep a step back that this we cannot do it. That is the only thing I would like to say. And we have Dr. Nargisa. She's a fellowship, she's doing a fellowship in skull-base surgery with us. She will also tell her experience with cisternostomy in our center.
Good evening, everyone. I am a young neurosurgeon from Russia, and I have been doing my residency in Siberian part of Russia. What I want to say that I'm so happy that my experience in emergency trauma neurosurgery started from cisternostomy. When I was doing my residency in Russia, mostly I was in big neurosurgical centers where usually neurosurgeons do some elective cases. And my experience in trauma was very bad and poor. Before coming here, I felt some guilty that maybe it's better to at first have some experience in trauma and then to join to Dr. Aipcherian. But once I came here, I realized that I can see how cisternostomy works. I can see how a brain become relaxed, and there is no doubt that now I will do cisternostomy, and I don't even want to have any experience in decompressive craniotomy. Thank you.
We would like to have comments from Professor Goyal and questions from all the young neurosurgeons, criticisms. We are open, and of course, Juha should have his take. Victor Hugo and all the other experienced panelists should talk on this. Manuel is here as well.
First of all, my dear Aip, I'm very happy to hear you and see your great confidence in this procedure which you have developed and which you have nurtured and which you have seen grow. And now you have people who are following it throughout the world. I know I am seeing articles being published in various journals. See, one thing that if you really ask me, this word decompression, decompressive craniotomy or whatever, decompression word, I don't like this word, like remove the bone and remove. Although there are many, I know many young people in the world who are doing decompressive craniectomies. And if I say I don't like, there will be a revolt against me. And people will, say, what nonsense, we are doing this procedure all the time with wonderful results. So one thing I don't like, I have never done, I don't want to do, is a procedure which is decompressive craniectomies. I have seen disasters, I have seen deficits, I have seen permanent deficits. You do decompression in a trauma patient, the brain bulges out, and that bulged brain is completely necrotized and edematous and gets finished. So that patient with bulging brain out of decompressive craniectomy will never recover from hemiparesis of any kind, if he recovers eventually. So that is my feeling about decompressive craniectomy for tumors, for anything. I don't do decompressive. And now I don't do decompression for any spinal problems, spinal laminectomy, lumbar canal stenosis, spinal canal stenosis, anal Chiari malformation, and I don't do decompression of any kind. So one procedure which can overrun the decompressive, I will welcome it in any format. That is one thing. Second thing is, I have seen myself, I don't do too much trauma myself, but I have seen some patients where, they were being conserved and they worsened. And then I tried to open the cistern and ventricle, and there was a gush of fluid came. See, what matters in trauma is, of course, the initial impact of injury. How much is the initial injury? How much is the damage? And how much is the, whether recovery can happen or not happen? Depends. Number one is how much is the extent of injury. Now, the second thing is whether surgically we can help this patient, whether we can do something. And I have a feeling that in many of these cases, the cisterns are full and loaded with CSF and they are under pressure. Even when they are, when the brain becomes tight, the pressure, the cisterns are actually compressed. But if you know how to open the cistern, you will find a gush of fluid. I think that gush, do you find a gush of CSF coming when you do this cisternostomy?
Yes. When we do cisternostomies, when we open the cisterns, we find blood coming out first. When we open the first thing that we find is a lot of blood in the cisterns. And we wash, then there will be a lot of CSF coming out. This is what all the boys and Nargisa and everybody has seen this, that the CSF keeps coming out, and the brain starts becoming lax and lax and lax.
The other thing that I would like to know is whether any kind of ventricular drainage, because we are eventually draining the CSF. And sometimes the brain can be so tight that it is difficult to reach the basal cisterns, despite all the efforts. Now, do you think in this situation, ventricular drainage can be of any help or no?
The ventricular drainage, in my opinion, it really, since the ventricle doesn't communicate with the parenchyma, it plays with the total volume inside the intracranial compartment. So the compliance of the brain can be increased by draining the ventricle, and of course it will help to get into the base. Of course, yes, if you put in a ventricular drainage and drain even 4-5 ml, that will help you to have a slightly lax brain. But what we do is we apply a little bit more force than necessary. Maybe it is not good on our part, but on the frontal lobe, we apply a little bit more force. And once we get into the ventricle, then once we get into the cisterns, opticocarotid cisterns, then things are better. So this is what we do. But your point is very, very valid. Yes, to get a good compliant brain, even with very high pressure, maybe we could put in a ventricular drain, and maybe that will help us to get into the cisterns.
What the very fact that many people in the world are doing this technique now, obviously it has taken up, and I wish and I hope that this technique flourishes further, and the patients with head trauma who need urgent treatment of some kind, the indications are sorted out when to do this procedure, when not to do this procedure, when the patient is, suppose he's absolutely down whether this procedure should be done or not. The indications, the techniques, and all those things have to be technically, formatted in a proper manner. I am sure it has been done. And let us see what the future says and what others in the panel say about this. But my feeling is the very fact that so many people are doing now, there has to be a substance and there has to be a validity. I hope you can place this point further and in a solid manner in front of the huge audience that is watching you today.
Thank you, sir. Thank you very much. Anybody could want to comment? Manuel is doing it in Russia. I suppose Manuel was trained with us for some time. Manuel, would you like to say something?
Yes. First, thank you so much, Professor, for your conference today. Well, Here in Russia, I already made 5 cisternostomy cases. I already have documented the cases. 4 of them have very good results. The only problem I face here is some dogmas with the neurosurgeons here, because some people still they don't know, because here, for example, some people who make trauma cases don't make a skull base, and the one who make a skull base don't make trauma cases, and they still it's hard for them when you explain sometimes, like, we can put the bone back because you can see how relaxed is the brain. And you explain to them, to some doctors, after we make the decompression, after we open the system, what happened? It's not only CSF going out, it's going out from the parenchyma, visual rubbing space, and then going out. And for that, the brain is not relaxed. Because some people tell me, but we can make ventriculostomy. And I say, it's only 20 milliliters in the ventricles. It's not gonna work. For that, this is the a physiological part of the cisternostomy. But here,
it's a mindset change, Manuel. It will.
Yes, it's hard.
I mean,
it's hard.
If you see resistance, you must understand how much resistance we had during the initial years.
Yes. As I tell you, Professor, I just figured out, and I congratulate you again, because when you was young, 13 years back, start to talk about something new to people, I cannot figure out, because I explain to people and I show the papers and I show the results, and still it's hard. It's hard, slow process, but it's going hard. I hope to have another hospital next week to continue with the cisternostomy cases, and have at least 3 hospitals more, and that was going to be spreading.
Yeah, I must remember that during my earlier years, the few people who were very supportive was Dr. Jim Osman, Dr. Goyal, and of course later on Juha, when he came and saw, Dr. Garnett, who came and saw from Calgary. He was a direct student of Dr. Drake, and when he came and in 2010 he came and visited our hospital, and I was talking about cisternostomy. He was a big critic at that time. He said, just show me in the theater. And he came to our theater, he saw a few cases, and he said, this works for sure. And I remember, and their group proved the CSF shift edema. If you see the paper of CSF shift edema, it's from Foothills Hospital, Calgary. So I can never forget the people who stood by me in this journey. Now we are seeing the light at the end of the tunnel, but there was time when there was no light at all, because I remember in trauma meetings, we were ridiculed, and we were all over the world. People used to initially laugh at us, then people used to fight with us, but now it's changing. So I would like maybe Juha or somebody in the panel to say some comments on this, and of course we have a lot of questions. We will answer that slowly later on.
My thinking is that can you hear me?
Yes.
Okay. My thinking is that when you go subfrontal to a small cap, you should go first to lamina terminalis. This is how I have done always. So to open the lamina terminalis, then open the anterior cisterns and also Liljeqvist membrane, and then the opening of the lamina terminalis helps a lot to get a little bit more space to open the cisterns and to move around there, to open them well under the microscope, microsurgically. And then what I have done, of course, these are aneurysm cases, rupture, subarachnoid hemorrhage cases. So I leave a small catheter inside the third ventricle, so for intracranial pressure monitoring and also CSF release when needed. So this is also for postoperative treatment. So this is how I think. I saw, for example, in the second video, I saw that lamina terminalis remained unopened all the time. So this is, it's a pity because this gives some more space. How much is there? Okay, you get 10, 20 milliliters out. This is a lot in this situation.
Yes, I completely agree. I used to do that before, but then when we had few hydrocephalus, I was thinking that maybe the cistern blood is going into the ventricle and producing this hydrocephalus. That's why we stopped. But even then, now if there is severe swelling and this add-on, the lamina terminalis add-on is a great boon, because when you open the lamina terminalis, you have a gush of CSF, and that definitely helps with the compliance. So. And you have Professor Goyal, all of them have seen really tight brains lax up and become tame with opening of cisterns. It's the same with trauma. Unfortunately, we don't have these masters doing trauma. That is the problem. So nobody, I mean, I cannot imagine Professor Goyal or Yuha in theater for trauma. That's the problem. So this is what is our disadvantage. I want you guys, all the young guys listening to us, to have these, grab these guys, the masters in your place, grab them, take them to theater. They will tell you how to open the system. They will do it in 5 minutes. I'm telling you, 5 minutes is all it takes. 5 minutes. Okay. Dural opening.
Professor.
Yeah.
Yes. Also, is one of the problem is some people are very jealous with the microscope. They think the microscope is it's true, because some people they say like, why we don't use microscope in trauma? Is because they say if use the microscope have a cost to put the back, and in some places they see that like an extra charge from all the patients in normal trauma cases, and it's one of the parts is hard to work with that. And
this is not technical. This is not a technical thing. It's a mindset change. It will come slowly. So it's a mindset change. See, mindset change is the major problem here. So it will come slowly. We will slowly go ahead. I would like Yuha to have some closing remarks now, that I think we have exceeded our time.
We have time. We have time to discuss.
Oh, yes. So then we will answer the question. There is this question from Bandung. He was asking, somebody is asking, Eriko is asking, when to stop performing cisternostomy after the brain is enough lax, if not all the cisterns that you mentioned or before has been opened, or after we open what number of cisterns. So it's very simple. You have to see the basilar quad, which means both the PCAs, both the superior cerebellar arteries, and obviously you have to open the opticocarotid cistern. You have to go lateral to the carotid, and then you have to open the membrane of Lilliquist to see both the P1s, both the superior cerebellars, beginning of superior cerebellars, and then put a feeding tube into the prepontine cistern. That is the end of cisternostomy. That is the end of cisternostomy. So that is it. There is any condition that makes us stop in performing this procedure? No, we've never had to stop the procedure. So I don't. Well, at one time I've had a PCA, I mean PCOM rupture. I've had a rupture. My consultant retracted, and we've had a PCOM rupture from the carotid. And that time we had to clip it off, and then we had to stop cisternostomy. This is one time, maybe in so many cases. So that's the only time we had to stop cisternostomy at that point, and that patient did not do well. But otherwise, we did not have to stop the procedure at any point of time. So any other questions? If anybody would want to ask, please go ahead and ask.
Are there in chat some questions?
No, just a comment, dear friend Ipe. I have been several times with you in Nepal, and I don't have any doubt about the benefits of this technique. But I think, for example, here in Latin America, most of the brain surgeons should know this technique, because I think that this is really good. This is the same when we have to operate a big tumor, for example, in posterior fossa. First, we need to open cisterns. Then after the brain is relaxed and we can remove the tumor much better. So I think the brain surgeons in Latin America should know this technique. And I hope in next November we could make this Congress, Intercontinental Congress in Acapulco. I think your talk is going to benefit brain surgeons, especially here in Mexico. Thank you very much. Congrats for your really, really good technique.
Thank you, Victor. Thank you very much, Victor.
So I think one of the important things here is that you take the microscope in traumas. This is of course big resistance in that. The nurses will tell and the consultants will tell you that it has been never done. We never use that, and there is big resistance. So it is difficult to change and takes a lot of time. So, but after it has been introduced, then everybody is saying we have always done it. So we have done it, and we were in the front line to do that, and so on. So it is important. So, and also for the young people, so it is a good opportunity to use the microscope in brain surgery, so in trauma cases, because many of the older neurosurgeons are not willing to come in the evenings or night for trauma. So it's very good opportunity to learn microsurgery in these difficult cases. So of course, after learning this technique. So I think this is cisternostomy is better physiological alternative than hemicraniectomy. So the hemicraniectomy is done so much all over the world and in China in excessive numbers. So I think it is very important for the Chinese neurosurgeons. They should learn this method and widespread its use. I know one center in China is doing that, but maybe more could be. And here is a lot of trauma cases, so they could be treated with this method. So these are my thoughts.
Thank you, Juha. I would ask my friend Bin Su as to what his thoughts are.
I thought he was in operation room. Liao is here.
Oh, Eugene Liao is here? Okay.
Eugene Liao is here. What is your opinion?
Would you like to say something? Abida is also here. Eugene Liao, if you would like to say something.
Hello, yes.
Hey, Binsu.
Hello,
There's,
Ben. Yeah.
Hello. There's Ben.
Yeah, Dr. Liao is translating your presentation to Chinese.
Okay, okay. Thank you.
Yeah,
Thank you so much.
I'm driving to my home because I just finished my work today.
Okay, okay. Okay, dear friends. So I hope to meet you soon.
Congratulations. Today, more than 1,000 audience watched your WeChat broadcast.
Wow.
In WeChat.
Yeah. Wow.
Thank you, Ben.
Thank you so much.
Okay,
Ben.
the message is going forward.
Anybody else? Any other comments? Abida?
Yes,
Your comments, please.
I congratulate you on your procedure, and as you know also that trained with Professor Goel and his thinking. I have never done a decompressive craniectomy and have stopped doing all other kinds of decompression. So kudos to your thinking, and I think it does make sense. And we should all, since I'm also not doing too much trauma, but the philosophy does make sense and it should work. And I think this procedure will come up in a big way in the future. Congratulations to you guys.
Thank you very much. Yuha, I think that would be it. We will close for today. And I hope I could get the message across rather, I mean, in the form of a class, so that I would want these take-home messages. Number one, it is just something that we start with an aneurysm surgery with. It's nothing new. Number two, CSF shift edema, and it's all published right now. So CSF shift edema and how to reverse it. And number three, how, as you said, to use microscope in trauma. So I guess these will be the take-home messages from my talk. And thank you very much. I was really honored, and it is always good to see you.